Imagine waking up one day and realizing that a fundamental part of your physical anatomy is literally vanishing.
Yeah, just completely altering itself.
Right. Not just changing shape a little bit, but actively, erasing itself. Because most of the time, I mean, when we think about a dermatological issue, we picture like a surface disturbance.
A rash, some redness.
Exactly. A temporary irritation that you treat with a cream. And underneath it all, the structural integrity of your body remains exactly the same.
But that's really not the case here.
No, it's not. So for you listening right now, imagine a condition that acts less like a surface rash and more like, well, a slow-moving architectural demolition crew.
Oh, that's a good way to put it.
A condition that permanently melts and remodels the physical structure of your body. Welcome to the deep dive.
Glad to be here for this one.
Today, we're taking a stack of clinical guidelines, specifically the British Association of Dermatologists, the BAHH guidelines, and a whole bunch of patient resources to explore a profoundly misunderstood chronic condition. It's called lichen sclerosus.
And it fundamentally shatters our conventional understanding of what a skin disease is actually capable of doing.
Right.
I mean, we are looking at a disease process that doesn't just irritate the canvas. It warps and shrinks the frame itself.
Which is terrifying. Our mission today is to answer one specific vital question that we found throughout these sources. How does lichen sclerosus fundamentally alter, and in some cases permanently erase, the architectural symmetry and structure of the vulva over time?
Yeah, because we really are talking about the literal vanishing of normal human anatomy.
So before we get into the mechanics of how the body reshapes itself, let's establish what we're actually dealing with.
Sure. So lichen sclerosus is a chronic inflammatory dermatosis. The exact root cause is still technically classified as unknown, but
Well, we have clues.
Oh, definitely. The clinical evidence strongly points toward an autoimmune mechanism.
Okay.
Researchers have actually identified autoantibodies to a very specific protein in the skin, which is called extracellular matrix protein 1, or just ECM1.
Okay, let's unpack this. What exactly does ECM1 do in a healthy body? And why does attacking it cause such a profound problem?
Well, think of ECM1 as the biological mortar holding the bricks of your skin together.
Okay, the mortar.
Right. It provides scaffolding, structural support, and it regulates the elasticity of the tissue.
So it's keeping everything stretchy and intact.
Exactly. What's fascinating here is, in lichen sclerosus, the body's immune system basically gets confused. It produces antibodies that target and attack that mortar.
Wow.
And when you destroy the scaffolding, the tissue completely loses its structural integrity.
That makes a lot of sense. And the sources mention this bimodal peak, meaning there are two major spikes in life when this typically appears.
Right, yeah. Frequently in prepubertal girls, and then most commonly in postmenopausal women.
So the immune system is actively dissolving its own structural support. To understand how the vulva's overall architecture changes, I guess we first have to look at what's happening to the building materials at a microscopic level.
Because if the foundation of a house changes...
The entire structure is going to shift.
Exactly.
Yeah.
And the clinical guidelines break down the histopathology. The cellular changes into three distinct events.
Okay, what are they?
First, there is epidermal atrophy. Second, hyperkeratosis. And third, dermal sclerosis.
Wait, let me stop you there, because those first two sound completely contradictory.
They do, yeah.
I mean, atrophy means thinning or wasting away, but hyperkeratosis means thickening. How can the skin be thinning and thickening at the exact same time?
Well, it makes sense when we separate the living tissue from the dead tissue.
Oh, I see.
Epidermal atrophy means the living, active layers of the skin are starving and thinning out. The life force of the tissue is diminishing.
Right.
But the body tries to protect that vulnerable, thinning, living layer by overproducing the very outermost layer of dead skin cells.
The keratin layer.
Exactly. That overproduction of dead cells is the hyperkeratosis. So you essentially have a microscopic layer of living tissue trapped beneath a thick, hardening crust of dead cells.
Wow, that sounds incredibly uncomfortable. And the third factor, the dermal sclerosis.
That happens deeper down. The collagen fibers beneath the surface undergo something called hyalinization.
Hyalinization.
Yeah, they become dense, hardened, and glass-like.
Okay.
Clinically, this combination turns the skin an ivory or porcelain white color. But the texture is the real indicator here.
What does it feel like?
The medical literature describes it as taking on a crinkled appearance, like cellophane paper or old parchment.
That is just If we think about normal, healthy general tissue, it has to be incredibly resilient. I mean, the biological design relies on it being able to stretch, to move, to accommodate friction without breaking.
Absolutely.
It sounds like lichen sclerosus takes a stretchy, resilient rubber band and replaces it with a piece of rigid, dry tape.
That is a perfect analogy.
So the moment that tissue needs to stretch, whether a person is, exercising, using the bathroom, or engaging in sexual intimacy, it simply can't expand.
It just tears. The extreme fragility of this parchment-like skin is why patients experience such profound pain.
Right.
Minor, everyday friction causes painful fissures, which are these deep, agonizing cracks or cuts in the skin.
Ugh, that sounds awful.
It is. The tissue is so fragile that patients frequently develop purpura or ecchymosis.
It is bruising, right.
Yeah, bleeding just beneath the surface, presenting as deep, dark purple bruises.
Which means just the normal friction of, like, walking or wearing a pair of jeans could cause the skin to bruise and split open.
It absolutely can.
And looking through the BSH guidelines, this mechanical damage triggers something even worse. I want to talk about the Kubner phenomenon. From what I'm reading, this seems like a terrifying design flaw in the human body.
Oh, the Koebner response is one of the most frustrating aspects of managing this entire condition.
Because it feeds on itself.
Exactly. It's a process where any trauma or friction to the skin actually triggers the underlying disease to attack that specific site.
So if they scratch.
Right. Lichen sclerosus causes this intense, almost unbearable itch. The patient naturally scratches the itch, which causes microtrauma to that superfragile skin.
Okay.
Because of the Koebner phenomenon, the body responds to that minor scratch by generating more lichen sclerosus lesions right there.
So the body's attempt to heal the friction damage actually summons the disease to that exact spot, creating more rigid scar tissue, which causes more itching, which leads to more scratching.
It is an inescapable feedback loop.
And because the skin is caught in this relentless cycle of inflammation and rigid scarring, we start to see the actual anatomical structures, the physical features that define the vulva, begin to warp.
The chronic inflammation essentially melts the distinct structures together.
Wow.
This is where the profound loss of architectural symmetry occurs. I mean, the vulva is naturally a complex, folded environment with distinct, separate features.
Specific architecture.
But lichen sclerosus obliterates those distinctions completely.
I was reading this section on labial resorption, and it was honestly difficult to process. The guidelines detail the loss of the labia minora, the inner lips. The text says they can shrink, flatten, and eventually be completely resorbed.
Yeah, it's severe.
Do they just slowly disintegrate into nothing?
Well, no, the tissue doesn't vanish into thin air. The relentless scarring process acts like a slow-moving physical fusion.
Fusion, okay.
Right. The delicate tissue of the labia minora is pulled outward and glued, essentially, to the labia majora, the outer lips.
Oh, wow.
The distinct valley, or separation between those two structures, just fills in with rigid scar tissue. Over time, the inner lips are pulled completely flat until the vulva loses that folded architecture entirely.
It just becomes smooth.
It becomes a smoothed-over, flattened surface, yeah.
That is a staggering alteration to someone's body, and the architectural distortion doesn't stop at the labia. The clinical notes on the clitoris describe a process called clitoral burying. When I first saw that term, I assumed the disease was actually, destroying the nerve tissue of the clitoris itself. Is that what is happening?
Actually, no. The clitoris itself, including its incredibly dense, complex nerve network, remains entirely intact.
Okay, that's a relief.
It is not eaten away by the disease. What happens is more of a structural sealing.
Sealing?
Yeah, as the scarring spreads, the prepuce, which is the clitoral hood, begins to fuse together. The scar tissue pulls the hood tightly over the glands of the clitoris and seals it shut.
Oh my God.
It traps the clitoris entirely beneath a thick layer of rigid skin.
It's like having a self-cleaning oven, but someone has welded the door completely shut.
Exactly.
I mean, the body is still shedding skin cells and producing natural secretions underneath that hood, but they have absolutely nowhere to go because the exit is sealed.
And that trapped keratinous debris begins to build up under the fused hood, forming what we call smegmatic pseudocysts.
Smegmatic pseudocysts.
Right. These are painful, swollen lumps trapped under the scar tissue. They create immense pressure on the highly sensitive nerve endings of the clitoris, and they can occasionally become infected.
Which would require surgery, right?
Often requiring surgical drainage, yes. All the normal sensation is either completely blocked by the thick scar tissue, or it's converted entirely into pain.
We are seeing a pattern here where the loss of architectural symmetry isn't just like an aesthetic change.
Not at all.
The fusion is actively constricting the natural openings and functions of the anatomy. The disease is erasing the outward protruding structures and aggressively closing the body's natural pathways.
And introital stenosis is the clinical term for that constriction.
Introital stenosis.
Right. The introitus is the vaginal opening, and stenosis means a severe narrowing. As the inflammation drives midline fusion, it frequently produces thick skin bridges at the posterior fourchette.
And where is that exactly?
That is the area at the base of the vaginal opening, stretching down toward the perineum. The new tissue forming there is that rigid, cellophane-like scar tissue we established earlier.
And it can't stretch.
It cannot yield at all.
Bringing this back to the reality of the person living with this, I mean, the psychological and emotional weight of that narrowing must be devastating.
It's completely life-altering.
We are talking about profound dyspareunia, painful sexual intercourse, or aparunia, where intercourse becomes completely impossible.
Because the moment any penetration is attempted, that rigid ring of scar tissue just splits. It causes agonizing pain and bleeding, which then, if you remember...
The Koebner response.
Exactly. It triggers the Koebner response all over again, worsening the disease. For many patients, it effectively shuts down the possibility of sexual intimacy.
That's heartbreaking.
It leads to profound feelings of isolation and a sense that their own body is betraying them.
And the betrayal extends to the most basic daily functions, too. I noticed the guidelines are careful to note that lichen sclerosus doesn't typically affect the internal mucous membrane.
Correct.
Meaning it doesn't travel up inside the urethra or deep into the vaginal canal. But the severe fusion of the labia on the outside physically impedes the urinary stream anyway.
Yeah, the scarring can create an actual barrier or canopy over the urethra.
Oh, wow.
Patients report severe burning pain with urination because the urine is highly irritating to those open fissures we talked about.
Of course.
We also see urinary retention because the patient physically cannot push the stream past the fused scar tissue, or the urine stream is deflected and sprays unpredictably.
Exposing more of the fragile skin to the uric acid.
Which again feeds the inflammation.
Right. And the footprint of this disease doesn't just stay isolated to the front of the vulva, does it? The visual diagrams in the BIHH guidelines show a very specific pattern of spread.
They do. The white sclerotic plaques frequently sweep downward to encompass the perineum and the perianal skin.
The area completely surrounding the anus.
Yes, creating a highly characteristic figure of 8, or hourglass shape of pale, hardened tissue.
So if the skin around the anus is turning into that same rigid, inelastic parchment, then passing a normal bowel movement becomes a physically traumatic event.
Yeah, absolutely.
The tissue is going to fissure and tear every single time.
It leads to extremely painful defecation. And we see a massive secondary complication here, particularly in the pediatric cases.
What happens with the kids?
Well, when a young girl with lichen sclerosus experiences that tearing pain, she becomes terrified to use the bathroom.
No.
Children will intentionally withhold their stool to avoid the agony. This leads to severe secondary constipation, impacted bowels, and entirely new sets of gastrointestinal issues, all stemming directly from this external architectural scarring.
If the body is doing this to itself, fusing the labia, burying the clitoris, narrowing the vaginal opening, and tearing around the perineum, how do we stop the demolition? Can this architecture be restored once it's lost?
That's the hard part. The most critical reality outlined in all the clinical guidelines is that these architectural changes, the fusion, the resorption, the narrowing, they're largely irreversible without surgical intervention.
Irreversible.
Once the tissue has fused and scarred over, no topical cream or medication is going to magically dissolve that scar tissue and unfuse the anatomy.
So what does this all mean? The timeline is everything. It's a race against the scarring.
Early diagnosis is the only way to protect the body's structure. The standard of care to halt the demolition is the use of ultra-potent topical corticosteroids, such as clobetasol propionate.
Okay, corticosteroids.
And the data supporting this is incredibly powerful. One longitudinal study highlighted in the guidelines tracked patients over several years and found that 93.3% of patients who were strictly adherent to long-term maintenance therapy experienced complete disease suppression.
Wait, over 93%?
Yes.
That is an astonishing success rate for halting an autoimmune process. But you emphasize the word adherent.
Because adherence is the dividing line between saving the anatomy and losing it. This is a lifelong condition.
Right.
A major pitfall is that patients will use the steroid ointment until the intense itch subsides, and then they stop applying it.
Because they think they're cured.
Exactly. But the itch is just the smoke. The underlying inflammation and the microscopic scarring in the fire continue to burn silently even when the patient feels totally fine.
So the steroids aren't just a symptom relief cream. They are actively shutting down the localized immune response that causes the architectural destruction.
They preserve the anatomy. Maintenance therapy, which usually means applying the ointment once or twice a week for the rest of the patient's life, keeps the immune system from attacking the ECM1 protein.
Keeps the biological mortar intact.
Exactly.
But what about the patients who are diagnosed late? The ones who already have severe structural changes, where the clitoris is fully buried or the introitus is completely narrowed? I mean, the guidelines mention surgery, but we talked earlier about the Koebner effect. If you cut into this tissue, won't the surgical wound just erupt with new lichen sclerosus lesions?
It would. Operating on an active flare of lichen sclerosus is like throwing gasoline on a fire.
Okay.
Surgery is absolutely contraindicated as a treatment for the disease itself. However, once the disease is completely suppressed and clinically quiet through strict steroid use, surgery is highly effective for restoring lost function.
So you have to put the fire out first.
Yes. And then a specialized gynecological surgeon can perform procedures to divide the clitoral adhesions, carefully unburying the clitoris and cleaning out those painful pseudocysts.
Okay.
They could also perform a perimealoplasty, which releases the rigid scar tissue at the base of the vagina, widening the introitus again.
So the surgery can't cure the illness, but it can give the patient their quality of life back, allowing them to urinate normally and engage in pain-free intercourse.
Exactly.
And aside from preserving the anatomy, there's another highly critical reason why getting this underlying inflammation under control is non-negotiable. The sources clearly outline a long-term cancer risk.
Yes. Having chronic uncontrolled lichen sclerosus carries a small but clinically significant risk estimated at less than 5% of developing into squamous cell carcinoma, which is a form of vulvar cancer.
That's definitely significant.
The chronic inflammation can also trigger a precancerous cellular change called differentiated vulvar intraepithelial neoplasia, or DVN.
For someone whose anatomy is already heavily altered by scarring, how would they even know if a cancerous change is occurring? It sounds like it would be hard to spot.
It requires vigilance. Patients need to perform regular self-examinations and maintain annual or biannual checkups with a specialist.
What are they looking for?
They are specifically looking for a deviation from their established pattern. A new nodule, a suddenly thickened plaque of skin, or crucially, an ulcer or fissure that simply refuses to heal despite their diligent steroid treatment.
Okay.
A non-healing ulcer on a bed of lichen sclerosus requires an immediate biopsy to rule out malignancy.
Let's synthesize what we've uncovered today. We started by pushing past the idea of a simple surface rash. Lichen sclerosus is a profound, lifelong autoimmune condition that drives chronic inflammation and rigid, inelastic scarring.
Right.
Over time, that relentless scarring literally remodels the architectural symmetry of the vulva, fusing the labia, trapping the clitoris beneath an impenetrable hood, and drastically narrowing the body's natural openings. It creates a cascade of physical pain and emotional isolation.
It really does.
But the vital counterweight to that heavy reality is that with early diagnosis and strict lifelong adherence to ultra-potent topical corticosteroids, this structural devastation is highly preventable. The architecture can be saved.
That's the most important takeaway.
As you process all of this, I want to leave it with the final thought to mull over. Throughout these medical texts, a recurring theme is that lichen sclerosus is incredibly underdiagnosed. Women suffer for years in silence, being repeatedly handed over-the-counter thrush creams by doctors who aren't looking closely enough.
That happens far too often.
Or even more tragically, in pediatric cases, the severe bruising and anal fissures caused by the disease are misidentified as signs of sexual abuse. This triggers devastating, misdirected investigations while the child remains untreated and in agonizing pain.
It's awful.
Given how profoundly and permanently this condition alters a person's physical anatomy, it forces us to ask a difficult question about our culture's relationship with female bodies. How many people are currently living in silence, enduring excruciating pain, and watching their bodies irreversibly warp, simply because society is too uncomfortable to teach women and girls what the normal, healthy architectural symmetry of their own anatomy should look like?
That's a huge point.
If you don't know what the baseline of your own body is supposed to be, how can you possibly sound the alarm when it begins to disappear?
You can't.
It's something worth thinking about. Thank you for joining us on this deep dive. Keep examining the world around you, keep questioning the surface of things, and always seek out the why behind the information. Catch you next time.